But welcome. So it's Dementia Action Week for the Forest. So it's great to be here, and thank you so much for inviting me along to today's session and for me to deliver today's session. So we are going to talk and focus on today about dementia, and probably a bigger focus really on delirium. Both are areas of clinical practice that I'm very passionate about. My actual role within the local NHS trust is I'm a consultant dementia nurse, and I've been in the post just over a year. And it's a dream job of mine to be in this job. So it's a great pleasure to be able to sort of deliver these types of sessions to a variety of people. So thank you for coming today. So the main talking points for today's session. So obviously we're going to just have perhaps a reminder or refresher about what is dementia. And as I said, our biggest focus today is delirium, and that's particularly for people with dementia who get a delirium. Then we're going to look at the differences between dementia and delirium, the related risk factors. For delirium, we're going to look at how we can identify delirium, particularly with someone who also has dementia, and then we're also going to focus on preventing and treating delirium. So what is dementia? So people may have seen a similar slide to this, or this slide perhaps in other presentations around dementia. So dementia itself is not a disease. So it's an umbrella term used to describe symptoms that cause many different diseases. So what that means is Alzheimer's disease is one of those diseases. Vascular dementia is one of those diseases. So dementia is that umbrella term for lots of different diseases. The four most common types of dementia in the UK, so Alzheimer's disease, vascular dementia, Lewy body dementia, and frontal temporal dementia. And these diseases are progressive, and symptoms do get worse, but the rate of that decline will vary from person to person. And I will say, just like to highlight, so dementia comes on slowly over a good number of months to years. It doesn't happen overnight. And that's important to think about when we come on to delirium a little bit later. Some of the main symptoms of dementia for people are obviously memory difficulties. So we'll be aware often people have some difficulties with short-term memory, and often longer-term memory is maintained or more easily accessed for a person for a much longer period of time when they have dementia. People will experience communication difficulties and also difficulties with functional skills. So what we mean by that is kind of everyday activities. So perhaps washing, dressing, feeding oneself, having a drink, and also cognitive skills. So problems processing information that people are given and take in. So dementia is caused by progressive damage to brain cells. So we've got, 100 billion different neurons in our brain, and that's what's being affected. So with Alzheimer's dementia, there's structural changes to the brain. So there's the formation of what we call plaques and tangles in the brain. But then with vascular dementia, that's then where there's been poor circulation problems and difficulty with blood getting into the brain, which then causes cell death. And obviously chemical changes in the brain as well that can affect communication between those neurons. So thinking about what is delirium. So as I mentioned with dementia, so dementia is a disease that develops over 6+ months to several years. But delirium is acute. There's a sudden change in the person. So delirium means an acute confusional state, and it is usually associated with being unwell. And as I mentioned, so an onset is sudden and it fluctuates. And it does affect the whole brain whilst the person has delirium. So it might be that we see a decline in a person's abilities. People may present with altered levels of consciousness or alertness. People will have difficulty concentrating. People may have perhaps more disorganized thinking. There are different types of delirium. So hypoactive delirium, which actually is the most common type of delirium. So this is where a person might suddenly become more withdrawn, perhaps really quite sleepy, perhaps not interacting with others, perhaps not eating and drinking very well. Sometimes those symptoms could be similar to what we, to depression perhaps. But again, depression doesn't happen suddenly. Depression happens perhaps over a number of weeks to months. But with hypoactive delirium, it's that sudden change. So I've suddenly, I've suddenly become quite withdrawn, quite sleepy, perhaps not interacting with others, perhaps not eating, not drinking. It's likely that that's a delirium. The other type of delirium is called hyperactive delirium. So this is where a person suddenly might become more restless, perhaps agitated, more hyperactive around their environment, paranoid, possible hallucinations. Now this is although hypoactive delirium is the most common, hyperactive often is the one that's thought of more often, because it might be that person with dementia who's perhaps wanting to leave their home, perhaps becoming agitated towards the people that they live with, their loved ones, or the carers that are coming in. So often hyperactive delirium is actually perhaps a little bit more of a concern due to the urgency of symptoms. And then some people can get mixed delirium. So they can have a mixture of both the hypoactive symptoms and hyperactive symptoms throughout the day, perhaps over an hour's time, perhaps. It can fluctuate quite quickly. Similar to dementia, people who experience delirium will experience those symptoms very differently. They will have different symptoms or different severity of symptoms dependent on the person and what might be wrong with them. So it's really important that we know about delirium. So firstly, it can be very stressful for the person experiencing delirium, and of course their loved ones, the people that support them. And people with dementia are 5 times more likely to develop delirium. So that's why it's really important for us to be aware of delirium, particularly for our loved ones with dementia, or the people that we support perhaps with dementia, because it's, that risk of getting a delirium is much greater. If delirium is missed, there's greater poor outcomes for people. So people with dementia are more likely to go into hospital and consequently stay much longer. Obviously the risk at the moment with or the recent risk of kind of COVID, so there's risk of people becoming more unwell if they go into hospital, developing perhaps hospital-acquired infections. People are more likely to be placed in care if they have an episode of delirium in hospital. So, I might have perhaps been a person with dementia, living well with dementia in my own home with support from family or loved ones, but going into hospital, perhaps, like I said, becoming more unwell, perhaps bigger or more evidence of delirium. So I might then end up having to be discharged for a period of time, perhaps to a care home, either for a short period, for a bit of convalescence, or longer term. And there is increased risk of death. So identifying, having that awareness of delirium, if we don't know those things, don't know about delirium, then there is increased risk of death for a person. And it does say there, so 30% of older people admitted to hospital will have an episode of delirium. So that isn't just people with dementia, that is both people without dementia and people with dementia. And when we perhaps look at the older age wards in hospital, so the GOAM general old age medicine wards, that it's likely that there's probably 70% of patients on that ward will have a delirium. So I mentioned dementia as one of the risk factors for delirium. So as I mentioned, so it's 5 times more likely if you have dementia or a cognitive impairment. And the risk of delirium does also increase with age. So the older you are, the more at risk you are of getting delirium. Because anyone of any age can actually get delirium. So children can get delirium, adults, teenagers, young people, people in their 30s, 40s can all get delirium. But the older you are, the greater risk of getting a delirium you are. So if you're a person with dementia and you're also perhaps in your 70s or your 80s, again, your risk of getting delirium is much higher. Other risk factors, so if you've had a hip fracture, again, you're at greater risk of delirium. It's probably due to the anaesthetic that you have during the procedure, and that kind of causing the brain to be a bit fuzzy, causing that delirium. Just purely by going into a different environment or going into hospital, that can be enough of a change for a person to cause a delirium. So often to our services within Gloucestershire, so into our dementia services, it's quite often we'll get a referral for a person perhaps who's been moved into a care home from their normal home, and we're being told that they're more confused, they're becoming agitated, or they've become, you know, really sleepy and withdrawn. That's because that change of environment alone has caused that person to become acutely confused, and that's what's causing that delirium. People with impaired vision and hearing, so if you have people who have those, then again that risk, you know, it increases the risk of delirium. People with urinary catheters, so risk of infection with urinary catheters increases, consequently increasing the risk of delirium. And it does have on there then acute illness or injury. Also reduced or impaired mobility and falls. So if you have people that you live with or you support, if they have any of those things, then like I said, their risk of getting delirium is much greater. So there's a national campaign around delirium, and we really want people to kind of think delirium because often it can be missed. So we're currently working within Gloucestershire on a new delirium pathway for people. So our kind of strapline is think delirium. So again, if there's been that sudden change, that fluctuating picture or presentation of a person, then we're encouraging people to think delirium. And if delirium is identified early and all causes are treated, it does frequently resolve and people have much better outcomes. So delirium is a reversible condition. So if you have a delirium, then we can reverse it by treating the cause of that delirium. So then it's likely that people will go back to perhaps their I don't like really saying the word normal, but their sort of self pre-delirium, or near enough back to that same state. Again, it's different for everyone, but people do recover from delirium very well. Yes, Lena.
If you get delirium once and you get better, does that mean you're more susceptible of getting delirium? You're more at risk of it once you've had it once?
Yeah, so if you've had one episode of delirium, that increases your risk of getting further episodes of delirium. So we will focus in a bit on looking at ways of preventing delirium. So obviously if we can keep well and follow the kind of guidance this evening as best we can, then, you know, we can reduce that risk of getting delirium.
Is delirium the same as confused? In the past, they used to say, is it called delirium now instead of confusion?
Yeah, so I think delirium is kind of a bit of an on-trend word at the moment over the past couple of years. So you're right.
Okay.
So it's those people that have become more confused quite quickly. That's a delirium.
Okay, thank you.
Good question. Thank you.
Okay.
Steve, I was really surprised to see that risk factors didn't include things like alcohol and drug abuse. And I just wondered how that sat with historic alcohol abuse or maybe drugs and some of the psychosis that happens following those sort of abuses. How does that fit with delirium?
Yeah, so people with alcohol problems, people with drug problems, so that's it. Yeah, if you're an alcoholic, say, then that would increase your risk of getting a delirium in the future. But I think I've probably focused on that probably more under the kind of causes of delirium rather than the risk factors. But you're right. But people with drug and alcohol problems would be at greater risk of getting delirium because obviously their brain is already a little bit more fragile. Yeah, so good question. Hadn't thought to put that in. Thank you. So NICE guidance, so National Institute of Clinical Excellence, so they have produced guidance on delirium. So it was initially issued in 2010 and then updated again in March 2019. So what that's telling us really is kind of what we're trying to do in the county. So assessing all patients for risk of delirium, if admitted, within 24 hours to initiate an individualised prevention intervention, so some sort of care plan for those at risk of delirium, identify and diagnose delirium, and then following the recommended management guidelines, including effective communication, reorientation, and non-pharmacological, so non-medication kind of strategies to manage perhaps a person's distress where possible. It does make reference to if we have somebody with a hyperactive delirium, so somebody who's perhaps paranoid, pacing around the environment wherever they are, then there are some guidance for how to manage that with medications. But again, that would be very last resort and often under kind of specialist guidance. So I've mentioned things about kind of, or that we're going to come to kind of prevention of delirium. So what we're going to focus on now for the rest of the session really is Pinch Me. So people may have seen or heard of this acronym before. So these are the most common causes for delirium for people with dementia. So it fits into, like I said, to Pinch Me. So pain, infection, nutrition, constipation, hydration, medications, and environment. Now, so they're the most common causes, but other things will cause delirium. So Sarah mentioned alcohol, drugs, somebody not sleeping very well the night before, that might cause the delirium. They might get up, they might be more confused when they wake up. So lots of things can cause delirium, but for the purpose of this presentation, we're just going to focus on the most common causes, things to look out for, and then thinking about how we can perhaps prevent that delirium for that person. So our first section is on pain. So obviously pain, so we will obviously, where we can, we'd ask a person, are you in pain? But we know with people with dementia, dependent on how advanced their dementia is, they may or may not be able to tell us that they're in pain or understand what that means anymore. So we do often need to look for those non-verbal signs of pain. So for a person with dementia, so fidgeting, becoming quite restless, shouting or banging, holding a particular area of their body, so perhaps holding onto their hip or holding onto their arm, calling out. So an example there is perhaps calling out for mum or nurse, or just calling out help me. If they're calling out for their mum or for a nurse, it might be that they're seeking some sort of comfort. What is the message behind that calling out? What does that mean? What does that person need? Reacting with fear or distress, particularly during personal care. People might shudder and perhaps cower and perhaps try and pull away if you're trying to support them with washing or dressing. Changes in body language. So this may include pacing, tight fists or hitting out, pulling away, or we might see symptoms of that hypoactive. So someone presenting with apathy, somebody perhaps withdrawing from what's going on around them. Somebody might be becoming, more into themselves, not wanting to do perhaps things that they normally would do. So what we would want people to do is to, again, thinking back to that sudden change, that fluctuating presentation, could this person be in pain? So as supporters of people with dementia, it's perhaps then looking out for these signs that, okay, is this pain? It might be pain. The person's presenting with some of those symptoms perhaps. So what are we going to do about it? So depending on your role, so it might be if you're a loved one of somebody with dementia, you live with somebody with dementia, it might be that you give some pain relief, paracetamol or whatever they could have normally. Does that help? Hour later, hour and a half later, have some of those symptoms reduced? Do they now appear more restful? Has that paracetamol helped? If it hasn't helped, it might then be linking in with primary care or a healthcare practitioner or somebody who's involved in your loved one or your loved one's care about requesting a review of their pain. a bit of paracetamol has helped for the short term, perhaps the person might need something stronger or more longer lasting, perhaps. I do often, I will be mentioning the Abbey Pain Scale when I deliver this session next week. Unfortunately, I haven't got a copy of that to show today, but people may have heard of the Abbey Pain Scale, and it's an observational tool to assess for pain in people with dementia who perhaps communication is difficult. So it's a rating, there's about 8 different areas and a score of 1 to 4 for each area. And higher the score at the end is then obviously the more likely they are in pain, and then it gives some advice about giving some pain relief if able, or obviously requesting that review, and then redoing the Abbey Pain Scale again about an hour later. Has your intervention helped? Has giving some pain relief helped? Has changing their position in the chair or their bed, has that helped? So it's, again, different for everyone, and we need to sort of think person-centered care. So, it's what's going to work for that person. So on our journey of Pinch Me, so it now moves on to infections. So the most common infection that we often think about is that water infection, that urine infection. Infection or urine infections are or can be very common for people with dementia, but it isn't just about a urine infection. It might be that the person's already got an infection, so they may be being treated for COVID, and they may be being treated for a chest infection, and then perhaps a day or two later they've suddenly become more confused. They've suddenly they've got that fluctuating presentation. They might be hypo or hyperactive in terms of their symptoms. So it's then, what do we do about that? So if it's an undiagnosed infection, then obviously we might, check the person's temperature just by feeling their head. Do we know the colour of the person's urine, perhaps? We might recommend a referral or a request for a GP to review a person, or another healthcare professional if they're involved. Often the first point of call in terms of assessment might be doing a person's physical observations, so thinking about doing their temperature, their blood pressure, their heart rate, their pulse, their oxygen saturations, perhaps. That might give us some clues that a person may have an infection, and it might be that we then take some blood tests to work out if it is an infection or not. Or we might swab a site, so it might be a wound, for example, so we might swab a wound, send that off for it to be assessed. So it might be cellulitis, for example, of the leg, or a pressure area that has become infected. So it isn't just urine infection, but obviously that is important to sort of think about. And we have put there that it is important to know a person's medical history of previous infections. It can be common if a person's had a urine infection once, then it's possible that they might then develop another urine infection in the future. I've got one lady who that I haven't seen her for a little while myself, but colleagues that are still seeing her, but quite regularly she would be developing some symptoms of hyperactive delirium, so becoming quite agitated, a little bit paranoid about her husband, believing that he was having affairs. And for this lady, again linked back to person-centered care, we knew for her the first thing we had to do was to dip her urine, because it's often for this lady that it was that urine infection. So following a kind of an MTT discussion with her GP and her family, we've now started on a long-term antibiotic, which is appropriate for some people, particularly if they've got quite recurrent urine infections. So that has reduced her episodes of delirium just by putting in that simple method of that longer-term antibiotic. But also, we've given the family a copy of the NHS drinks tracker, just so that every day she or her husband can then tick off every time she's had a glass of water, or just to make sure that she's drinking enough fluids, because we know if people don't drink enough fluids, then obviously that can then cause potentially cause a urine infection. So again, always linking back to person-centered care, and always thinking about what do we know about the person already. What might this be? Is this the same thing again? So when we're doing our assessments, so I will always do a pinch me assessment when I go out to see somebody, whether that's just to get a baseline or because they're exhibiting symptoms of hypo or hyperactive delirium. So that's kind of my baseline. If the person with dementia isn't able to give me all that information, then of course I'll speak to their carer or people that know that person best. That's a regular part of all our assessments within our services. So nutrition. So this is about malnutrition or poor nutrition. So people may not be eating as much for a couple of days. They then become hyper or hypoactive in delirium, so becoming more confused quite suddenly. So it might be that the first thing we do is just monitor the person's food intake for a couple of days. Keep an eye. Oh gosh, did mum have her microwave meal at lunchtime? Is mum having the amount of food that she would normally have? Ensure that food is in the person's line of vision. This is a really important one. We know that people with dementia, often their peripheral vision, so that side kind of vision, often can go, and people get what we sometimes describe as kind of that binocular vision. So if everyone does this, if everyone kind of does binoculars in front of their eyes, then it's often that all that a person might be able to see is what they can see through those binoculars. So if you're placing food to the side of the person or too close to the person, then it might be that they're not seeing the food anymore because it's not there to that person. So it's about thinking about ensuring that it is in their forward vision, their front vision, what they can see right in front of them. And also thinking about the colour and contrast. So if it's a white table with a white plate with perhaps light coloured food, is it because the foods and the plates become invisible? So this might be thinking about changing the colour of the plate, or perhaps putting a placemat down so there is contrast between the table and the plate, making it more vivid, making it pop out for a person. Sometimes thinking about reducing the amount that's on a plate can be helpful. Sometimes too full of plates might seem a bit overwhelming and perhaps an impossible task to eat all that food. As we get older, sometimes our appetites do reduce. So it might be just about perhaps initially plating up a smaller portion to then be able to give a little bit more if they've managed to eat that amount of food. Offering visual prompts and perhaps supporting the person to be as independent as possible. So that might be encouragement, verbal prompts. It might be feeding the person if that's appropriate. Also making sure that snacks are visible and that they're placed around for the person just to make use of. Sometimes little and often might be the best for this person at the moment for a variety of reasons. And sometimes we will pull in specialists. So sometimes we will pull in perhaps support of a dietitian or a speech and language therapist to kind of be part of that assessment of that person. What else could we be doing? What else do we need to think about? So again, when we're out doing our assessments, thinking about a baseline for this person, how much does this person normally have 3 meals a day, or do they only have 2? Do they like to have 5 meals a day? Do they like to eat just little and often? And then kind of supporting that person-centered assessment and that person-centered care planning to make sure that we're doing all we can to perhaps improve or maintain that person's nutrition levels. So C in pinch me is constipation. So often missed, actually, particularly for care home residents. I think it's about 60 to 65% of care home residents are actually constipated. And it's not thought about. They just think a person's gone off their food or not handed over perhaps more regularly. So again, it's about looking out for those signs. Is a person complaining of pain in their stomach? Are they holding their stomach? It might be that we think about taking some basic physical observations. Again, thinking about the person's temperature, the blood pressure, oxygen saturations, etc. Thinking about preventing constipation. So I've only heard of this recently, but the 3 Fs. So fluids, fibre and footwork. So ensuring that a person is drinking enough. If people are hydrated, and that ensures that the bowel continues to work regularly. If people are getting enough fibre in their diet, again, that aids bowels and keeps things moving. And then footwork, so that's more about mobility, so ensuring that people are getting up and moving around. If people are sat down all the time, then that can slow down the gut, make guts quite sluggish and things. So 3Fs is really important to think about. I could talk about a personal scenario. So my brother doesn't have dementia. He has learning disabilities and lives in a care home. So we found recently that he's independent with going to the toilet normally, but it's just been found out that just by accident, I think really, that he's been found to be very constipated. He's even been admitted to hospital because of it. So what we've implemented with the support of the care home and his learning disability team in the community is the 3Fs. So ensuring that they're now documenting how much he's drinking every day. Has he been drinking enough? Making sure that he is getting enough fibre in his diet. He's been on a specialist dietary care plan from assault for about a year. So it might be that the care home have adapted the food so much that he's now not getting much fibre or enough fibre into his diet because of those changes that they made. And also because of lockdown, people haven't been as active. So he's kind of been stuck in his, sat in his chair or lying on his bed, perhaps not doing the normal activities that he would normally do. So, we've adapted his care plan so that he goes for a walk 3 or 4 times a day after meals. We've increased his fibre in his diet and, increased his food or ensured that he's drinking enough. So, it's really important to sort of think about, particularly for people with dementia who may not ask for that extra drink or another drink. They may not be concerned about what they're eating. So it's kind of what we can do to kind of support people to ensure that they're hitting and meeting those 3Fs. So thinking about people who might have longer standing constipation, so it might be that they're on laxatives already. So it might be that it's appropriate to increase those laxatives for a period of time, obviously within the person's prescription or over-the-counter type remedies. Sometimes we need to kind of think about overflow. So overflow is more fluid, to be honest, coming out of the bowel, where the person is so constipated, all that's getting through is the kind of fluid. But people might think that's diarrhea. So it's kind of having a good understanding of, what you can see, for a person. Again, when I'm going out doing my assessments, so people don't like to talk about pooing or being asked about, what does your stools look like? But again, they're really good indicators for us to kind of sort of think about, okay, we use the Bristol stool chart, for example. So we might get that out to show a carer or a person with dementia, what do your bowels look like, your stools look like at the moment? Really sort of important and sort of things to think about. So a person, if they're still constipated, it might be that they need a medication review. So again, pulling in perhaps the GP or other colleagues from primary care or other healthcare professionals that might already be involved in a person with dementia's care. Mentioned the Bristol stool chart already, so monitoring, observing. So again, when I go out and do my baseline assessment, it might be that person isn't constipated, but I want to know about people's pooing habits. Is it normal for that person to go once a day? Is it normal for that person to go 3 times a day? We are all different. And as I've already mentioned, so no improvement, seek support from the GP. And going armed with as much information as possible, really. So it might be that you've already increased the fluid intake, you've already increased the fibre, you've already increased the footwork, but that still isn't helping. You've tried some over-the-counter remedies. You're saying that the stool chart is perhaps a type 6, where it's quite runny. So the more you can go armed with to the GP, then the more that they can then perhaps think about, okay, so the next steps that this person or this family have already tried a lot of what I would have suggested. So I mentioned hydration already briefly for bowels. So, hydration is really important. And NHS guidance is that people should be drinking a minimum of 1.5 litres a day unless they have a restriction placed on them because of certain medications or certain healthcare conditions. So, for the people that we're supporting, in whatever remit, it's making sure that people are drinking enough, perhaps printing off one of those NHS drink trackers so people can perhaps laminate it and then people can tick as they go. That can be really helpful, that visual prompt. So perhaps thinking about checking signs for dehydration. So again, back to perhaps physical observations. It might just be a feel of the forehead. Do they feel warm? monitoring the fluid intake. Monitoring output is really difficult, but if people are passing urine, thinking about what colour is the urine, and again, the NHS have a chart on looking at the different colours of the urine for the people to do like a self-assessment really to see if they might be dehydrated or not. So again, it might be helpful to have a copy of that available in people's homes and sharing it with people that you might support, and then looking at adjusting fluids as needed. When someone has dementia, it may be difficult to increase fluids. So you might need to sort of think about being creative. Okay, so they're not going to keep drinking cups of water, but what can we do? What can we encourage for a person to drink? It might be increasing perhaps fruit. So fruit has good water content, particularly, watermelon. But other fruits have fluid in, so that's adequate. Perhaps thinking about soup. Thinking about what's going on in my head. There are other other things that we can kind of think about. So it isn't just simply that glass of water. It's trying to get as much fluids into a person as possible if they're struggling with that. What are those?
Jelly.
Thank you. Yeah.
Jelly.
Yeah. Thank you. Have people heard of those? There's a couple of nods, but they're round sweets filled with fluid. I haven't seen them in person, but a colleague has, and the only, I guess, concern is that they're quite big. So it's just about how a person perhaps keeps and holds that in their mouth for it to dissolve. But they can work really well. So it might be that the people you're supporting, might just monitor for the first 24 hours. You've identified that they're not drinking adequate fluids. It's then, okay, so what do we need to do about that? So it might be, like I said, so introducing soups, fruit, etc. to a person's diet. Then if there is still no improvement, then it might be then perhaps a conversation with primary care or a healthcare professional involved in that person's care. It's also to sort of think about so that we've spoken about dehydration, but people who drink too much fluids, so that can cause a problem. So that can cause a chemical imbalance within the body. So again, it might be that you notice that they're going to the tap quite often. They've definitely drunk more than 1.5 litres of water today. We better monitor this for 24 hours, because if they're drinking too many fluids, then that will potentially cause a delirium. So it isn't just they're not drinking enough. Sometimes it's about drinking too much that is then causing those symptoms of delirium. So again, we'd still monitor perhaps for 24 hours. We then would still seek some guidance, support from a healthcare professional or involved in our loved one's care, or get someone from primary care to come out, or just have a conversation with us over the phone for a discussion about, okay, so what strategies could we put in place to help there. So the next element of pinch me, so medications. So these can cause delirium. So lots of medications, or all medications, come with some side effects. Some people might be a little bit more susceptible to some side effects. So thinking back to pain, so we may have identified pain as a problem for our loved one, and we'll call her Mrs. Jones. So Mrs. Jones, we've now got to prescribe some codeine. What do we know that codeine does? Codeine causes constipation. So it's now poor Mrs. Jones is in pain. She's now got constipation and started on this drug. She's going to get a delirium. So it's about being aware of side effects first and foremost of the medications that are being started, and then monitoring for those side effects. It might be looking at reviewing the drugs that the person is already on. Sometimes medication has kind of an end life. It won't work anymore because the duration of that medication, is no longer effective. Thinking about some of the dementia drugs. So sometimes people on donepezil, which is one of the cognitive enhancers for dementia. So sometimes if people are on that for well, perhaps say 3 or 4 years, they're sometimes people can experience a sudden worsening of symptoms, so suddenly becoming really quite aggressive or much more confused. And it might be now that donepezil needs to be reviewed and stopped, because that's causing problems now. We've had a great, it's been of benefit for a period of time, but now we think actually we've ruled out all the other causes of delirium. It might actually be the donepezil, so let's look at stopping it. Does that then help improve the person's symptoms? There's some correlation with dosages of some medication, so it might be that they need to look at reducing a medication or increasing a medication to look at resolving that delirium, preventing that delirium. We've mentioned side effects. I guess compliance potentially could be a problem, because if a person isn't taking a drug every day as they should, then their body may not be getting used to it. We say sometimes in the early stages of treatment, a person may experience perhaps a mild side effect. So again, with donepezil, so it might be that you get some stomach upset for the first perhaps couple of weeks of the initiation of donepezil, but then after those first couple of weeks, it might be that those side effects reduce and stop. But if a person isn't taking their medication every day as prescribed, it might be that some of those side effects last for much longer because they're not getting that medication up to what we call a steady state for it to be working. So long-term medications can cause problems, so we always encourage people to have an annual medication review of all their medications, so not just their dementia drug perhaps, but I know that a lot of GP practices now in their primary care networks have employed pharmacists, so pharmacists may now ring you or arrange a visit or get you to go into surgery for a medication review, and they're skilled with knowing about the drugs, how long they're useful for, obviously the side effects, and some pharmacists can prescribe, so they might be that they adjust some of the medications that you might be on or stop some of those medications that you're on. So it's really important both people with dementia have an annual medication review, but also perhaps carers, loved ones of people with dementia also would be entitled to that same annual medication review. Sorry, I'm conscious of time. I think I only had 45 minutes, but we're getting there. Hope people can stay on a few minutes late. Thank you. So I mentioned environment earlier on. So purely a person being moved to a different environment, so into a hospital or to a care home, can cause delirium. So where possible, we want people to stay in their own environments that they're familiar with. But obviously that can't always happen. So we do need to sort of think about some environmental factors. So it might be in your own home, so where you normally live, it might be perhaps the TV being on or the radio might be too loud. So that can cause a delirium. You might be trying to speak to somebody, the TV is blaring, that might get you confused and a bit agitated because you're not really understanding or misinterpreting what's being said. It might be other people in the environment are being very noisy. Thinking about light or bright sunlight shining through directly onto a person's face, so they may not know to say, or can you shut the curtains, and that beam of light directly into that person's face can cause perhaps some distress, cause a person to perhaps feel scared or panicked, and consequently become more confused. It might be perhaps a change in daily routines. So it might be a person hasn't had a package of care at home before, but to maintain them safely at home, it might be that a package of care needs to be introduced. But perhaps that stranger walking into their lounge, that might cause a person to become confused, might cause a person to become quite scared or frightened. That would be a delirium. Change in circumstances that affected their usual freedom, perhaps. Just trying to think of an example. So perhaps a person being admitted to hospital and being told to stay by their bedside, or a person kind of being encouraged to stay in the side room. That restriction, again, might cause a person to become worried, anxious, frightened, and increasingly confused. And then unfamiliar people working in that environment. So again, it might be, this scenario might be a new carer coming to see me today at my own home, or it might be, if I'm in a care home, it might be unfamiliar carers who don't know that I like to be called Steve, don't know that I like to have a cup of tea in bed before I get washed and dressed. That might be enough to cause me to become more confused, more upset, or withdrawn because of those changing circumstances. So environment is often not considered enough, I don't think. So that is definitely an area that, you know, that again is a focus of our assessments when we're going out or speaking to people with regards to referral. So some top tips. Sorry, I'm just going to have a sip of water. So for people with dementia and, you know, perhaps with the delirium as well, so ensuring that spectacles or that the person's own spectacles are available and they're, you know, in good working order and they're clean, making sure that hearing aids are available and working. The amount of people who don't get their hearing aids serviced, I think they should be serviced every 6 months or have the tubes changed. I think that's what my mum's advised, to have her tubes changed every 6 months. But, you know, for years she never did. You know, it's making sure that, you know, batteries are working. Another example, I often mention dentures. So people make sure that they have, you know, their dentures in and that they're their own dentures, because I have known of a situation where a person was, you know, had somebody else's dentures in, and we were really confused about why they weren't eating and drinking. And it wasn't until a family member who, you know, didn't recognize that smile, you know, that they had the wrong dentures in. So it's really important that you know, people do wear their own hearing aids, glasses and dentures in terms of thinking about top tips. Cognitive stimulation. So that doesn't necessarily mean, you know, a psychologist leading a cognitive stimulation group. It might be just interaction. It might be a conversation about a person's life history, activities that they like to do, hobbies. It might be showing them some pictures in a book, or perhaps putting their favorite television program on, doing a crossword. Regular reorientation during the day. So reminding people that it's Tuesday morning or Tuesday afternoon, Tuesday evening, whatever, reminding people, oh, it's 11 o'clock in the morning, oh, it's 11 o'clock at night, you know, just those simple verbal prompts just to try and support that person when they're in this heightened state of confusion. A lot of areas now have special clocks, so it has the day, the month, the year, the time, and says whether it's sort of daytime or nighttime. You know, that might be helpful. And is helpful for people with dementia anyway. So, you know, again, if a person's got dementia, they're already going to be quite confused. So with a delirium, they're going to be more confused. So the more top tips we can kind of follow, the better. Telling people clearly what is happening and why before you approach them. You know, speaking slowly, ensuring good eye contact, really important. Encouraging sleep. So I did mention earlier on, so sleep is, if people have a poor night's sleep, then that would cause a delirium. You know, it's, you know, I'm frustrated and angry the next day if I've not slept very well. You know, so a person with dementia whose brain is already compromised, if they're not getting enough hours or enough good quality sleep, then it's likely then that will cause them to be perhaps more delirious, whether hypo or hyper. It does say there, so at night time, sort of where possible, be as quiet as you can. Perhaps no medications after the person's gone to sleep, so they're not woken up, and sort of keeping people as active as possible during the day, you know, can really aid and promote good sleep. Encouraging family to bring in familiar objects and to visit where possible. Obviously, that has been difficult during COVID. But, you know, things are opening up again, and it does mention there, so avoid bed or ward moves. So I was chatting to a colleague the other day who works in one of our hospitals in the county. You know, their relative had 12 bed moves in like 48 hours, and, you know, no wonder the lady was more confused. No wonder she didn't want to eat and was unhappy about being there. No wonder she tried to escape several times. You know, it's just, it's not good enough. So where possible, we're encouraging, obviously, in all environments to reduce bed moves or ward moves, whether that be care homes or any of our hospitals. But, you know, it can be difficult. So finally, I know rabbited on quite a bit, and but these are kind of our kind of the take homes really from today's presentation. So as I mentioned earlier on, so think delirium. If there's been that sudden change, that acute change, someone has suddenly become much more confused than they normally are, think delirium. Perhaps when you're supporting people, perhaps a carer has contacted you, or the person themselves contacted you, perhaps to say, oh, I'm really worried, I feel more confused, or my loved one's more confused. You yourself think delirium and perhaps give some top tips. Think about advising they speak to their GP or their community dementia nurse or their dementia advisor, or I mentioned GP. Think delirium, mention delirium. So delirium can fluctuate, and the changes do occur suddenly, and that's kind of a really important message. It isn't somebody who's been confused for 12 weeks or a year. It's somebody who's got that sudden worsening levels of confusion. Observe closely. So, the person potentially can be at risk of falling. So it might be that we need to pull in some other healthcare professionals, physio or OT, perhaps, to think about some aids for the short term, perhaps. Identifying people at risk of delirium is really important. So if we know what those risk factors are, then we know that, okay, Steve's got dementia, he is at greater risk of getting delirium. Let's try and prevent that by managing managing Pinch Me, for example. Pinch Me, really great acronym to sort of think about. Again, these are the common causes of delirium. They aren't all the causes of delirium, but like I said, they are the most common causes. And person-centered care is really important with all the work that we do, all the support that we provide. Delirium can take weeks or sometimes months to fully resolve. So, like I said, it is a reversible condition, but particularly for people with dementia, it can take a bit longer to resolve fully. It might be that perhaps due to the delirium, their levels of confusion, are really high, but it gradually improves over a number of weeks or perhaps a number of months, particularly if the whatever's causing it is treated and managed, and we are keeping up with those top tips that we spoke about on the slide previously. So as Lena picked up on earlier on, so risk of further episodes increase when unwell. So if you've had an episode of delirium, then it's, it puts you again at greater risk of getting another delirium. So be mindful of that, and do seek support or guidance from primary care or dementia services as required. And that's really important to sort of think about. They can aid the assessment and perhaps identify or commence treatment for the cause of delirium for that person.